Hello, everyone. My name is Jim Pavlik, and I'm the Senior Program and Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus. I am a certified tobacco treatment specialist and the lead trainer and curriculum designer at BHWP. And today I want to talk to you about a common framework used to guide interactions with someone engaged in a behavior that may contribute to undesirable health outcomes. That framework is called the stages of change, a component of a larger model of how the decision to change is made within an individual and how it can be supported through the application of various well-timed strategies. Not every peer-reviewed analysis of the stages of change has found that it's effective. Whether the stages of change works or not is dependent on whether the clinician abides by the model's recommended interventions or not. We know that tobacco use is among the deadliest of all activities, certainly the deadliest activity that is allowed by law and which Americans engage in recreationally. About 500,000 people die from smoking every year. Between a third and a half of lifetime smokers will die of diseases directly caused by their smoking, diseases like heart disease, cancer, COPD, pneumonia, and diabetes. As care providers, as family, friends, and neighbors, we feel the desire to help people quit very strongly, and our impulse is to direct people to the gold standard of care right away, and that means medication and counseling, or at least a referral to the Colorado Quit Line. But nicotine is a powerful drug of dependence. It has a 32% capture rate, which means that about a third of individuals who use nicotine recreationally will develop a problematic use pattern. It's not uncommon for individuals who have quit using other substances to fail to quit nicotine, or to report that abstaining from nicotine was much harder than maintaining abstinence from those other drugs. We need to understand that when a drug speaks to its user, it speaks in the user's own voice, and it tells them powerfully fearful messages like, "Everything would be more boring without me. You can't handle your stress without me. You can't live without me." The knowledge that they may die from their habit should be a powerful motivator. We know that, and they know that. That they can't quit nicotine despite this knowledge leads to higher levels of stress, as well as sometimes shame and guilt. Which is all to say that we can try to help too much. Used inappropriately, the stages of change can hurt the trust between client and provider, increase stigma and shame, and prolong, perhaps indefinitely, a cessation attempt. Used appropriately, the stages of change can help us provide just the right level of service that the user needs and no more. With that in mind, let me introduce you or reintroduce you to the stages of change. In brief, the stages of change refers to the 5 positions a person may hold in relation to their willingness to make a behavior change, like quitting nicotine. And these stages are pre-contemplation, contemplation, preparation, action, and maintenance. And the remainder of my talk will go through each of these in turn. What contemplation means is that the client has no interest in quitting, at least for the foreseeable future. At any given time, this is roughly speaking about 25% of all smokers, although this number can be higher in some communities. A few years ago, my organization was able to survey about 600 clients in residential substance abuse treatment facilities in Florida. 35% of the 130 individuals receiving court-ordered drug treatment services and who also smoked had no interest in quitting. It's pretty high, but it's not the majority. As this stage's name implies, many pre-contemplators, probably most of them, will eventually think about quitting. Over time, many of the reasons that keep the desire to use nicotine high disappear, and the pre-contemplators do become contemplators. Contemplation is easily the most complex stage of change. This is the stage where the tobacco user holds at least 2 opposing viewpoints in their mind. The relationship between these viewpoints can be quite nuanced, but we normally think of it in terms of they know they should quit, but they haven't yet come to the conclusion that they will, at least not soon. We normally quantify this as they want to quit, but not before the next 6 months. In the language of motivational interviewing, they have ambivalence, 2 valences, 2 sides acting against one another, a position that favors the status quo, continuing to smoke, because change is hard. Our job is to get them to shift their mental balance from one favoring stasis to one favoring change. You'll often hear people ask, what do I do with individuals who are not yet ready to quit? And I want to be clear that the phrase, people who are not ready to quit, includes both pre-contemplators and contemplators. And that means there are 2 answers to the question, what do I do with them? With pre-contemplators, the answer is almost nothing. And I know that's hard to hear. You should still advise them to quit. You want them to know that you care about them, that you care about their families, and that quitting nicotine is the best thing that they can do for their health. But mostly, you just want to let them know that if they're ever ready to talk about their options, you'll be there ready to help them. For contemplators, the right course of action is to engage them in a discussion. You want to ask open-ended questions that encourage the person to talk about why quitting nicotine is important to them, to talk about the risks of continuing to use tobacco as they understand them, and maybe add a few more risks for them to consider, to talk about the benefits they will receive if they change their behaviors, and to talk about the barriers they perceive and provide them solutions to those barriers. And each time you follow up with the client, you want to return to this conversation until they're ready to make a quit plan. Now, I use the terms importance and risks and benefits and barriers and follow-up. These are common terms you'll see in a lot of documentation, including from accreditation sites and Medicare Medicaid reimbursement documents. They're also known as the 5 R's: relevance, risk, rewards, roadblocks, and repetition. The goal is to get the person to talk about themselves in relation to their nicotine use, but in a way that favors progress toward behavior change. Allow the client to talk about the benefits they receive from use, but always in that part of the conversation on the benefits of quitting. Allow the person to talk about the roadblocks, but make sure to talk about the solution to those roadblocks afterward. And I'm going to add a 6th R. Be sure to have the client talk about their resources, their strengths, their resiliency, their determination, their toughness or grit, their family, their church communities, their friends, anybody they can. In preparation, a person has made the decision to quit, and we normally put a short time horizon on this. They want to quit not at some random point in the future, but soon, within the next 3 months. During these 3 months, what happens? Well, a frequent thing that can happen is a person will say that I want to quit 3 months from now, say in July. But when July finally rolls around, what do they say? I want to quit 3 months from now, and on into the future. So what's going on? Well, change is scary. And the drug is whispering in their ear, saying things like, you can't do this, you're not ready. Basically, their confidence is being undermined, and to the extent that they're distinguishable, their motivation is being independently undermined. So we need to do the things that drive up motivation and build confidence. To build up and maintain motivation, we're just going to go back to the 5 R's. To build confidence, we want to make sure that they have the skills they need to quit. If they smoke to relieve stress, we want to help them develop and practice new stress management techniques. If they smoke when they're bored, we want to help them find things to do with their time, ideally new things since they won't act as triggers. We need to be constantly taking a read on their confidence level and being supportive, letting them know that what they're attempting is hard, but that they are competent, and they have a team of supporters ready to jump in and help. The action stage lasts from 30 days before their quit attempt and up until 6 months after it. Not everyone wants to set a quit date, but when an individual is nervous about setting a quit date, that's a clue that their confidence isn't as high as it might be able to be. At this point, the person should have a well-articulated quit plan that includes not only their quit date, but also some other concrete actions associated with it. Many individuals taper down into their quit date, or they will buy a certain number of packs of cigarettes and say their quit date is the day that they're gone. Others will hold a funeral for their last pack of cigarettes. Others will clean their entire house. This serves the function of removing the triggering smell of cigarettes, somewhat, from their house, but mostly it is used to symbolically tie them to a cleaner, healthier future. Help your client figure out what quitting will physically look like for them and try to add a symbolic component. Quitting is the absence of smoking, and it's sometimes hard to notice things that aren't there. So we want to make quitting a positive presence that they can use to mentally anchor the start of their journey. Also help the client to develop their crisis or relapse plan. Who will they call when they have an urge to smoke? Also role play with them their main triggering times, locations, and people. Don't just ask them what they're going to do when their friends ask them to go on a smoke break at work. Ask them, how are you going to tell Nancy that you can't join her for a smoke break? How will you feel if she gets mad at you or makes fun of you or looks at you with her puppy dog eyes? Remember, nicotine wants them to use Nancy and her sad eyes as an excuse. We need them to practice saying no so the drug doesn't have a space to intervene. The maintenance phase kicks in when the abstinence habit and all its associated behaviors have been practiced for about 6 months. At this point, frequent check-ins with the client continue to be warranted. What new triggers have they noticed? Also, reinforce the positive aspects of quitting. At 6 months, the client's carbon dioxide levels have returned to normal, their risk of infection has dropped, blood pressure's back to normal, the heart and lungs have started a long journey to repair themselves. All the damage done will continue to undo itself with time. So continue to offer your support and always be celebrating successes with them. One final note. We have discussed the stages of change as a linear process from pre-contemplation to maintenance. In reality, individuals can skip phases, reverse course, or linger in one box for years. Our task is to identify which stage of change they're in on the day we're talking to them and give them the right intervention, the one designed to move them to the next phase. That could just be supportive advice with no requirement to act. It could be evoking motivational change talk, helping them construct a plan, or calling them for a last minute, you can do it. Thank you for your attention, and I hope that you're enjoying your symposium experience.